planning and advice, and I think you'll do fine. I changed these slides around, and I was happy to, because I saw the other speakers talk about ICD-10 more, which I thought was the most important thing. But I think that we'll talk about the updates. 2015 is a critical year in Obamacare, and it really starts to impact you. Fortunately, for doing women's health, it's not the big impact, but you'll see it impact everyone around you. 3 years ago, when I gave the first talk, our hospital was a 3-hospital system. Next year, it was a 4-hospital system. The next year, it was a 5-hospital system. And next year, it'll be a 13-hospital system. And that's all because all the incentives that Obamacare gave you early are now expired, and now there are penalties. And the penalties are so severe, you can't make it. Remember, the essential point of Obamacare is that there's too much waste in the system, and the system can't stand under the burden of all the expenses. So they're going to take 25% or $1 trillion out of the system. $1 trillion or 25% is a lot. The best hospitals make the average best hospital makes 2, 3, 4% profit margin. And if you take 25% out of that, then everyone will go bankrupt. So it's hard to, as a right-wing Republican, I'm not supposed to talk politics, I am in most things. I always tell you I'm a medical communist. I like Obamacare because it really does help the people. I don't think it's sustainable, but I think we're changing the system. So anyway, if you take 25% of the system, everybody goes bankrupt. So with Obamacare, the essential point is, if you're the top 50%, you win. If you're not the top 50%, you lose. And when you lose 25% or more, you're not going to survive. And that's why you're seeing all this activity around you. But here's how it impacts you as a physician, as a nurse. So first thing, the good news is the sustained growth reduction formula was repealed. It was expired April 1st. You know why politicians wait till the last minute? It expired April 1st. The first cut was 15 days later, and on the 14th they repealed it so that there wasn't going to be any cuts. 21% cuts were gone. All the providers said, if you cut me 21% more, I'm not going to provide the services. The Democrats or Republicans were playing politics. They knew they had to fix it, but they wanted to add a bunch of riders onto the bill. They couldn't wait any longer. They had 1 day to get it done. They did. It increases, instead of reducing 21%, it increases rates by 0.5% the second half of this year, and then 0.5% every year to 2019. If they're forcing the government, and I'll show in further slides the announcement, they're going to switch from fee-for-service to pay-for-performance. They're already doing that. But the cuts that were canceled are going to be paid by an increase in out-of-pockets for the seniors and reducing payments to hospitals and nursing homes. The doctors come out, we're always coming out poorly, but we come out okay on this for now. What? Pretty neutral. But it could have been worse. So they're optimists, the bright side of it. So accountable care organizations, although mostly it's for the Medicare, CMS, the insurance companies are already looking at it, because if you can do it if you can make a profit and survive on CMS money, they know you can make a profit and survive on their money. So the next stage for all of us is going to be ACO success is delivered by having clinically integrated network. Now, officially, according to the Act, the Affordable Care Act, there has to be a significant amount of physician leadership, but I'm finding a lot of that leadership is token. They're on the committee, but they really don't make the decisions. But at least they have to be there, and we'll have some input. You have to have an IT structure, because they don't want to have to review your records to see if you have what's your readmission rate, or are you giving everybody the vaccine in your office. They just want to push a button and say your rate is 72%. That puts you at the 47th percentile. You don't get 2%. You have to have critical mass. So if you notice, a lot of you are being recruited, if not already, to go into hospital systems. Hospital systems have their ACOs and their integrated networks. You don't have to be an employee to be part of the integrated network. You just need to be the hospital or the integrated network, or the ACO needs to say that they have a group of doctors they contract with. If you're a primary care doctor, you get to pick one, so pick carefully. If you're a specialist, you're allowed to be in more than one. And I know in our group, there's a lot of consolidation. Our internal medicine chair just resigned. He resigned because they said we had 200 doctors 3 years ago. We added 400 doctors over the last 2 years. He complained at one of our meetings that he hasn't met half the people the hospital's hiring. He knows personally some of them are horrible doctors, and their answer exactly was, we don't care. We're going to bring them on board so they don't go someplace else, then evaluate them, and we have an evaluation system that I showed you before and I'll show you again, and then we'll decide if we want to keep them. So we're going to get the docs that are get them all, then filter out over the next couple of years as the rewards and the incentives turn to penalties, and figure out what you have, what we have left. So what I want you to do is be the top 50%. Okay, you already are. You're at this meeting. You're here on the last day. I've seen there were a quarter of you at the course yesterday afternoon. You already care. Caring and knowledge will put you way ahead of everybody else. The people that keep going and saying, I'm going to keep doing what I've been doing for the last 20 years, they're not going to make it. They're just not going to survive. So first, I'll do with the good news first. The good news is contraceptions worked really well. Increase in just pills. There's an increase in long-acting contraception, but just the pills, which you can measure very easily. 24 million extra people got it with no copay. That saved almost $500 million in out-of-patient costs for OCPs, and that gets money going to our economy, the public's economy. Uninsured fell from 20 to 15%, and the last full year of data we have, or about 10 more million people improved. We predicted for our system that we would break even or have a loss in 2014. We had the biggest profit ever. The biggest surprise was the $20 million that we normally spend on indigent care. It was cut in half because they had insurance. And so, you know, we always put 20, 30, 40 million dollars in reserve to take care of the drop-ins and the non-insured, and that's fallen. It's even better for young adults from 30% to about 20%. The failures are, the biggest failure is, and we now have a new member of our executive committee, is that the plans are either changing to high deductible, which so month to month, so people can choose their plan, and they say, well, I'd rather have the plan that's $300 a month than the one that's $700 a month, but their deductible is $2,000. And then when they come in for a service, and all of a sudden they get a bill for $900, they say, but I have insurance. Yeah, but then their EOP will tell them, yeah, but you haven't met your deductible yet. So they're unaware when that happens. The low payment rates are becoming a bigger problem. So in the past, the insurance companies had to have a gigantic infrastructure to go out to the 3,600 OBGYNs that are in New Jersey. There are 105 in Oklahoma. There's 3,600 in New Jersey. So to negotiate with each of those offices was a big pain for all the different insurance companies. And yet there's another announcement this morning that insurance companies are consolidating. There's 5 down to 4. There'll be 3 major insurance companies left. And then instead of having thousands of people in the insurance companies dealing with thousands of offices, because that's just OBGYN, internal medicine, family medicine, everything else, they have these large integrated networks. And they just go to them and say, we will give you X amount of dollars, you know, for this DRG code, for this disease, this code, take it or leave it. If you don't want it, the other organization that's twice the big as you said they'll take it, and you'll be left out. So they're able to derive lower payment rates. And we have a new person on our executive committee that's now an executive, and he's dealing with the insurance company. He reports every month. Aetna's holding us up for ransom. Their rates are ridiculously low. They say they will cut us. They've sent a letter to all our patients saying we're negotiating with your hospital and with your doctor. They are not. We don't feel that they're negotiating in fairness, and we plan on dropping them January 1st. They send these letters out before, and then we send the patients call and they complain, and then we're stuck. But we you know, we're getting bigger, and so we drive a harder bargain, and we'll see. The problem is now that when the insurance companies do that, they have a narrower network, and that's the big problem, the narrow networks. It means longer drives for patients, longer wait times. And again, they're tough negotiating tools that the insurers use against doctors and the hospital. Then within that, they have inner tiers, and you can even have a second or a higher tier within the network. And it gets very confusing. And also, if you're not in the inner tier, they have 300,000 patients in your area, and you're not the inner tier, and when they call up, they say, well, you can see that doctor if you want, but it'll be a $90 copay. But if you go to see this doctor, there's no copay. You're gonna lose business. So that the failures, and everyone knows there's a failure with that. And again, they have great promise to the groups that they negotiate with, but it's the old, you can make it up with volume. Well, if you're losing money, you don't make it up with volume. So this is a problem. Patients are complaining about the narrow networks. So there's two groups that are fighting. There's a Center for Consumer Information and Insurance Oversight. Part of the Health and Human Services is trying to eliminate, or at least have oversight over the narrow networks. And then the U.S. Chamber of Commerce, which is unfortunately part of the same government, but they're funded by the National Retail Federation, all the employers that say we want lower costs for our insurance that we're offering to our employees are right now, today, for the next couple of months, fighting over this. So, getting back to the Accountable Care Organization, what it does for you. So the ACO, and most payments are going to go to ACO over the next couple of years. I mean, so you're going to, whether you're part of it or not, it's going to happen. That's what's part of the, I started with the SGR reduction. The SGR change said, fine, we're going to not make $250 million worth of cuts, but you're going to have to do this. And so now that they passed the law, it was just in April, they're going to go ahead and start implementing these cuts. There's 33 quality measures. So your hospital, your practices, when you become a medical home, will then report these to Medicaid. Again, you can report them to Medicaid. Aetna can ask for them. United can ask for them, and as part of the contract with your integrated network or the ACO, they'll have to give it to them. There are four main domains: patient care experience, coordination, patient safety, preventative health, and looking at taking care of the at-risk. That's where all these nurse navigators come in. And then you get a score. If you get a good score and you're in the top 50%, you get most of your money back, but not all of your money back, because there's going to be savings. It just looks like it's going to come from 50%. 50% of the savings is going to come from 25% of the hospitals, and then the rest will be split. I don't want to go too much detail into, here's the pointer, into each of these. I'll show you some of the things that I want, because I want to pick on or highlight to you the things that you need to do that you're going to be graded on starting this year. So here's why it's all happening. We had some incentives, and they ended at 2015. And all these things take away 2%. So if you're in the bottom 50 percentile for readmission reduction or something like that, you lose that 1 to 3%, say 2%, for all your bills, So for our organization, which is now a $4 to $5 billion organization, half of which is CMS and Medicaid, we lose 1%. We lose $50 million, 10 to 50 million, so we lose that much, and you can't lose that much money. And that's one thing. So you're hurt. Right now, our patient satisfaction up here is in the 47th percentile. It's going to, just this year, it'll be $4 million. The hospital goes crazy. The hospital, for $1 million, hired the Gallup people to go ahead and fix the problem. I think they're doing it incorrectly. What they're doing is they're trying to move everybody from 4 percentile points. So everybody has to move up 4 percentile points. First of all, it's not fair to OB/GYN, because we're at 80, the average is 55 or 60%. We're at 80 already, and I tell them it's because we're wonderful. But part of it's that, you go to the ER, something's wrong, and you may not get a good answer. 97% of the time, you're walking out with a healthy baby, and you're really at the happiest time in your life was going to that hospital. And so everybody's really happy. So we have a good rate. But they want us to increase 4 points. Well, we only have 20 to improve, so that's a big move. The people who are at 50 percentile, they can move the 4. So, but my philosophy, and they're spending $1 million to do this, and so they want to move 4 points. So what they're doing, they spent $250,000 on stools to go in each room And what the rule is now, you have to go in, sit in the stool, be eye height to the patient, talk to the patient. On the TV is running, your doctor's name is Dr. So-and-so with a smiley face. So when you get the survey's first question is, do you know who your doctor is? Well, they just have it on the TV. Did your doctor, ask you, did you understand everything? We have a script. You have to say, how you're doing this morning? Is there anything I can do for you? And at the end, we have to say, did you understand everything I explained to you? That I talked to you about. But my philosophy is you take the people who are in the bottom 10 percentile. And what I did, and I said it as a joke, and the other thing's not working now for a year, so they've gone to my formula. I said, if you're that bad with patients, I'm figuring you're a psychiatric problem. You have a problem. If you can't relate with problems, you have some personality disorder. Something wrong with you. And the chief of psychiatry, they take the bottom 10%, goes with you on rounds in the morning, and he sits there he just hangs around, sits there, and he says, last meeting, he said, I'm totally amazed. He said, people walk in, say, hi, Mrs. So-and-so, how you doing? Before she says, I'm having a pain, she says, that's okay, don't worry, we'll see you tomorrow. You're gonna have a test today, bye. And she said, how is she ever gonna? She's not gonna have a good feeling with that experience. And then we have lots of residents and things like that. So each of these things count, and you're going to be graded. So they're grading all those 400 new primary care docs. They're all being graded. The ones that are doing well, they'll offer a new contract to. The ones they won't. They won't. But those docs have already missed out because the other integrated network is already evaluating their docs, and they know that the reason we're letting them go because they can look up on, the government websites what your scores are. So let's go through some of them. So 2013, patient experience, still patient experience, but you see the pie is changing. Now there's mortality rates, and again, as I said, for women's health, luckily most of the things aren't with us. I thought they'd be coming soon. They're having so much difficulties with it. They're looking at efficiency, again, outcomes, patient satisfaction, and clinical process of care. But let me go through them specifically. So here it is, very complicated, very slide. But here, this is where I want you to look at that. The things that you're going to be graded on that you can do. First thing, I didn't believe in skip. I'm an infectious disease guy. Skip was you give them all the antibiotics, and you reduce the wound infection rate, which reduced your rehospitalization rate, wound infections. It worked in general surgery patients, but the application, the antibiotics they wanted, didn't work in OBGYN. Don't worry about them anymore. They took them out this year. They weren't supposed to be out. They just took them out about 2 months ago. So those are gone. Discharge instructions, the patient will be asked, did you get instructions in your hospital? We'll make sure they get instructions. The patient care experience, it's going to be, a lot about the hospital, but also about doctor communication. You'll get your grade, and they'll really will focus on that for you. The outcomes measures, we're very lucky. It really has very little to do with OBGYN, except for, I'll show you where there's going to be some. So right now, our grades in women's health aren't that bad, except patient satisfaction is going to be probably the biggest thing, and then some of the hospital measures I'll show you that you'll be graded on. So again, outcomes, not a lot to do with us, and there'll be some patient safety indicators. So the patient safety indicators, there will be. You have your postoperative sepsis rates, your wound infection rates, and your accidental punctures and lacerations. So you nick that's why we had the lecture on bowel and bladder perforations. You nick that, sure you can fix it, you won't be sued, but it'll come up on the score. If you're one standard deviation away, someone in that organization will know about it and tell you to trend differently. If you're 2 standard deviations away, I'm supposed to tell them, you need to fix this, we need to come up with a plan, and if you don't fix it, there's going to be a lot of trouble. And trouble meaning specifically, we may not rehire you. They don't want to get a low score on this because they'll lose it all. They just don't lose a little, they lose it all. Again, that 2% is not for those patients that had to be readmitted for a wound infection. It's every bill they send for everything from that institution. So again, wound infections are important, and lacerations and punctures are important. And sepsis, we're being involved now. We're involved now with the big sepsis initiative. And again, they've tried for 4 years to see if they can get the doctors to do it, and it's hard. We're busy. So what they've done is they've empowered the nurses. So the nurses will have a sepsis protocol. If the pulse goes up, if there's a fever, if there's anything else, they don't wait for the doctor's orders. The sepsis initiative is started, labs are drawn, doctors are notified, antibiotics need to be started within 1, 2, 3, 4 hours, depending upon the entity, and the list of antibiotics that are appropriate are given, and we're going to follow that. It's probably okay. It looked like we'll probably overtreat some patients, but they want to keep their rate down. Yes, sir. You said, what sepsis protocol? Yeah, yeah.
Because she came in pain, her pulse was high,
right.
Had a little bit of fever, they immediately started.
Right.
Like,
the ERs have that. I mean, the ERs have that already. If pneumonia, you're graded on how soon you get the antibiotics on board, and you don't wait for the doctor's order. For the doctor's order. Yeah. So as I said. Yeah. And this just started for us in the last couple of months. It's all brand new. So you'll know, if you go back and look, or you go back and when it happens, because a lot of our patients don't have sepsis, they have these things in place. They're not waiting for us to do it. They're not training. They're going to start to train us. We're going to have meetings that are business meetings to go tell us what the hospital's going to do. But they don't want to lose on these. Again, as we go back, it's a large part of their payment. If 33 initiatives, if 6 of them at 1 or 2%, they lose a lot of money. So those are important. So what can you do? Sepsis, the hospital is going to do your sepsis, and all you got to do is stay out of the way. I didn't like the skip stuff. I think it impacted the overall hospital rate. You gave too many people antibiotics, and I think we developed some resistant organisms. But it doesn't make a difference. That's what they were going to do. That's what the government was measuring, and the hospital was going to do it no matter what. I said, it's not true. This doesn't work. I don't hold my doctors to it. They said, then your doctors will be penalized. And they said, if you don't believe it, go change it. I tried for 3 years. Finally, data came out, partly from our hospital, saying it doesn't work, and they finally just stopped it. But it took years and years.
Skip is out. All of those 6 skip measures are out?
Yep, pardon me?
All of those skip measures?
Yeah, the skip measures are gone. So the wound dehiscence rate, it's better for you if you're in the hospital and the wound looks bad, to address it right away. And I open them up a little bit, I even keep them a little longer. I send off cultures. I want to deal with that wound early. It's to me, opening up a little area, draining up a hematoma, say after a C-section, isn't a big deal. That patient goes home, she opens up the incision, she comes to the ER, she's admitted, it's bad, your score's going to do. So first thing I do is I tell patients to come to so they call me up, it's 4 o'clock. I know it's hard, you want to go home. I don't tell them to go to ER. I said, come to my office. They come to my office, I'll have somebody there, hopefully you'll have somebody there. They'll look at it, they'll say, fine, put a heating pad on it. I'm going to take these 2 staples out. We don't use staples anymore, but we'll take these 2 staples out. It's going to drain a little bit. Go home as long as you don't have a fever. We'll see you again in 2 or 3 days. You'll reduce. Otherwise, you say, now it's 9 o'clock at night. That's fine. I'll say, if you don't have a fever, come to my office in the morning. If I worry about it, I say, they say, well, there's something that looks like a bowel sticking out. I say, maybe you should go to the hospital. But I'm trying to prevent wound infection. If you have a wound infection, you don't want them readmitted. Again, I don't want to play the system too much. But a wound vac costs a lot of money. But it costs a lot of money to the hospital. Hopefully it doesn't cost a lot of money. I want to make sure it doesn't cost a lot of money to the patient. It does work. It's just expensive. But it may prevent that readmission and something else. And the hospital is almost, I don't think they'll argue with you if all of a sudden they say, because they'll also look at your cost per patient. If your cost per patient's high, if you say, but my wound dehiscence rate is half what everybody else is, and my sepsis rate is half, they'll say, fine, keep doing it. What are you doing right? We're going to tell everybody else. Because the amount of money they spend is always less than the amount of money that they're going to lose, because they have to save all this extra waste. Actual puncture and laceration, you just careful and just realize that it's a little more serious. One thing I will recommend is if you're not sure the way when you dictate it or when you write it down, don't say, I suspect a puncture, because then the coder is going to look at it and puncture and bill for puncture. Say, I'm keeping them after to watch their bowel function or watch their bladder function. Just don't, if it's there, don't lie. If it's there, yes. If it's not there and you're concerned about, don't say, because once you say concerned about puncture to the small bowel, it's coded, it's there. Okay. So, readmission rates. Starting September 30th. So it's all happening now. That's why this is perfect timing for you because you're going to go back and you're going to be well informed. So hospitals with readmission rates, high readmission will be penalized 3% of every payment. Again, that's 3% of $5 billion. Or really it's 2.5, that's Medicare. So it's $60 million, so it's a lot. And the readmission rate, luckily, is not to do with us. Heart failure, MI, pneumonia, COPD, hip and knees. New Jersey doesn't do well. They know already, because it's already July, that every single hospital will be fined. The average fine is going to be based on where you rank, so it's anywhere from 1-point-something% to 3%. The average is 2%, and in 2017, coronary artery bypass will be added to this list. Luckily, C-section rates, what they talk about, aren't on it yet. Hysterectomies, other things. Yes, ma'am. It's a readmission. It'll be the original hospital or doctor will be penalized. So otherwise, what I do is we have 13 hospitals. I'd say go to that hospital when we readmit you, and it won't count. Yeah, it gets credited to the original doctor and hospital. Again, so other things, hospital-acquired conditions, C. diff, pressure ulcers, catheter infection wound. This will be affected by. You will have an effect on this, and they will monitor you. You've probably seen your scores already. They've sent you every year, and they'll tell you what your admission rate is, what your mortality is, what your complications are. We get that every year, and again, I'm supposed to talk to the people 1 standard deviation away and put a plan in place for the people 2 standard deviations away. The bottom 25%, will have their payments cut by 1%. Wow, 1% is not much. When the average hospital in Jersey's profit margin is 0, they're break even, they're surviving. The best hospitals in the world, Cleveland Clinic, Mayo, are about 4 or 5%. We last quarter were 9.2%, and that's because this organization really knows what it's doing. They're not nice. I don't like working for them, but they know what they're doing. We'll be secure. We'll have jobs. They know what they're doing. Some of you have already joined groups, in hospitals and ACNs and ACOs, you need to look and look at the strong ones. They don't have to be nice, you're not really marrying them, you're just gonna go to work, with them, but they'll make sure that you have a job in a hospital, and they're not coming to you and say, oh my God, if we don't do this critical thing, we're gonna be bankrupt. They're rolling in dough, they're doing well, but they're getting it from other hospitals. They're taking it from other people. And those hospitals have other providers. One hospital already had to close, and you think, it's a hospital 30, 40 miles south, it shouldn't affect us. Well, the 9 OB-GYNs from there went to another hospital. Those 9 OB-GYNs displaced the other OB-GYNs that were there. Because they don't need all those OB-GYNs because specialty's not part of that. They went to another hospital. That other hospital finally was one of our hospitals. It displaced those doctors there, and in fact, instead of going to another one of our hospitals, they went to a competing hospital, and so all of a sudden we lost 1,200 deliveries like that because some hospital 40 miles south that we had nothing to do with closed. So there's going to be some effect. But anyway, the main thing is you are going to look at your C. diff, your wounds, your catheters, and things like that. Fortunately, as I said, or maybe unfortunately, the hospital knows this. If I have a catheter in that's more than 24 hours, it's either pulled or a nurse calls me and tells me they're pulling it. And if I said, no, she had an injury, I don't mean to the bladder, she had into the bladder and I want it in for a week or two, then they'll leave it in there. But now I just spilled the beans. I had a bowel perforation, or bladder perforation, so I'm in trouble anyway. But this is where you can be, again, cognizant that your hospital, your system's is going to be affected by this. Obamacare is all based on value-based purchasing. That's how we get from the old managed care system. That's how we get from payment for for each case to based on outcomes. So anyway, it doesn't make a difference how much it costs to take care of that patient. We could have an extra nurse navigator, a person calling them up every day. If they don't get readmitted to the hospital, we don't lose points in all those measures, it's worth it, okay? Because hopefully the value-based purchasing protocols and projects improve the system, prevented pressure ulcers, and save money overall. So anyway, a coalition of health system insurers met in January. Again, they want to change the financial incentives. They kind of knew that the sustained growth, reduction thing was going to come along, or hoping it would come along. They're going to move the bulk of the payments to value-based purchasing range by 2020. And again, it's with cost and quality as part of the arrangement. And at the same time, the new HHS secretary said, and this is in June, or in January, said that their plan, because of this change that they were anticipating, that half of all Medicaid payments will be based on quality in 2018. Now, how do they get you to do quality in your office? And that's medical homes. Medical homes, we'll talk about in a second, are basically for primary care now. The OBGYNs are the demonstration projects now. We're starting ours this year, and they'll pay you if you if you give everybody their vaccine, if you talk to them about smoking cessation, and we'll go through that. Again, so value-based purchasing, we're already doing that. Aetna, just to see some examples, and you may have it in your area. I'll tell you our example. Aetna in Maine said they lowered hospital stays and readmissions, and they say that 28% of their claims are now under the new arrangements. United Healthcare plans to increase the amount paid under value-based purchasing by 20% this year. Hospital systems are already experimenting. We have the second most profitable ACO in New Jersey and the 7th most profitable in the country. We've got, I think, $10 million back last year, but that $10 million isn't a bonus from the government. It came from some other hospital. It came from some other place. And they're looking at bundle payments. And here's where it affects us a little. So the bundle payments are all going to be in those things that count, the heart surgery, the hip and arthroplasty and stuff like that. So I said, it doesn't matter to me. I don't really care about this. So they called me in about the heart surgery bundle. And let's take a number. So $50,000, the bundle is, person comes in with a diagnosis of heart, that needs heart surgery, that's the whole payment. For 30 days, anything that happens, they get ulcers or wound infection or readmission, C. difficile, it's on your dime. The hospital says, fine, we could do it for $40,000. So we'll make $10,000 profit each one if we keep our rates down. And so they have programs for sepsis, and they have a wound team that looks at the wound, and they have all that stuff. But then all of a sudden, they call me in, and I say, why are you calling me in? Well, you know those patients that are in the heart service that get at work, those women that get a workup, and all of a sudden they find a mass on X-ray or radiology or something. They said, yeah, I go right up, I take it, I work them up and stuff like that. He said, don't do that. He said, that CAT scan you ordered, that test you ordered, all that's on our cardiology dime. Wait 30 days, start to work up then. I said, 10 centimeter mass in a woman that's, it's over. It may be cancer. And they said, well, we'll have to work with you on it. And we haven't gotten back to the table on it. So you may be affected because you may not have patients on a bundle, but you'll be consulted or you'll see patients on a bundle. And again, when you start ordering things in that patient, especially if it's the 28th day, they'll eventually get to you and say, could you please schedule her? In the next year, you'll hear them say, you know what, we're going to send her to you. Her bundle's over on July 18th. Please schedule, if it's appropriate, please schedule and see her at that time. So the bundles will have a little effect for us now, but in other departments, other areas, big, big, big. Clinical pathways, that's where we're going. An example is U.S. Oncology Network. Again, bigger and bigger and bigger networks. There are 1,000 oncologists in 30 different practices. They work with McKesson. McKesson wants to make money. And the National Comprehensive Cancer Network. And they develop pathways. Pathways that say, you know what, this chemo, they're based on good clinical evidence-based care. But if that good clinical-based care means that chemotherapy that's less expensive or can be administered in a less expensive way, then the insurance companies say, we want that. And then they go ahead, so WellPoint goes ahead and says, if you use this pathway that we've blessed, we'll give you $350 when you put her on the pathway, and we'll give you $350 for each month they're on the pathway. So there'll be pathways, and there'll be incentives. For us, we have pathways in OB/GYN. Every year they tell me to develop 3. I develop those 3 pathways, and then we know that that we're going to save $250,000, okay, for 30 docs, okay. And so we go ahead and I say, it's a little extra work. The pathways are pretty easy with the EMR. It'll be right there, but I really want you to do it. I'll give you lectures. I'll bring grand round speakers in to have you understand we're not doing it because it's cheaper. We're doing it because it's best practices. Once you understand it, you'll be more apt to follow it. And if you follow it 75% of the time, we will give you a $5,000 bonus. And we're giving them $5,000 to $10,000 bonuses for each of 3 measures. And they try really hard to do them. And it's not hard to get them to do it because it's best practice. We're not saying, delay surgery, don't do a hysterectomy.
Wait 30 days to evaluate this mass.
Yeah, 30 days to evaluate this mass is going to be an issue for us. But that's not a clinical pathway. It's developed for the right. That's some bean counter telling me that. So, Medicare shared saving programs. Again, you're saying, well, I don't do a lot of Medicare, and all this stuff is CMS. It's not CMS. The insurance companies are doing the same thing. So from this month, and if you haven't been called already, when you get back, there'll probably be a letter on your desk. The application from the hospitals to go in that shared savings program is at the end of this month. They have to send a list of all the doctors that belong to their ICN, Integrated Care Network, and all the doctors that are part of their ACO. The good news is the act that was supposed to expire that says the docs took risk, no longer, they can't give you risk. They can't say, yes, if we make $10 million, we'll give you $4 million to split among the doctors based on how well you did. But if we lose money, you're going to have to pay 25% of that. They cannot attribute a loss to you. So right now, if you sign up, look at the fine print. If they add it, it's an internal contract. It's not. You're protected by the federal government. You cannot get a contract saying that you're at risk for this program. Specialists, OB/GYN, primary care can only pick 1 ACO, but if you're specialist, you can pick more. So if they're coming to you and say, oh, you should sign up for ours, you better make your decision. We're going to only be open until next week, and after that, you can't sign up for anybody else. And you got to pick the one you want. You can't. A specialist, you can pick more than 1. And again, it's open not just for docs, it's open for the nurse practitioners, the PAs, and anybody in your office. If we have physical therapists and stuff that bill Medicare patients. So here's what's going to come a couple of years from now. We're starting as part of the demonstration project. For everyone else, for primary care, patients at a medical home is a model of practice that gives you accessible, active participation care for that patient and the family. They receive care for a practice that's called the medical home, and it appears to improve quality. There are better reimbursement for that. We get an average, we have a primary care office in the same building as in the same floor, not even connected by walls with our OB/GYN offices. And they see a patient for the same thing we're seeing for a patient, so they get 7% more. But you have to provide all the covered services. Now, I'll show you the covered services for us. In 2008, the NCQA worked with family practice, college physicians, the osteopaths, and pediatricians to define exactly what a medical home needs to do. And then you get accredited, you get recognized, and you get payment based on that. So you get payment, you'll get an extra 2, 3%, 5%, 10%. Remember, that's coming from somebody else. The government's not giving you a gift. They're taking it from somebody else and giving it to you. So if you're not the group that's doing well, it's going to come from you. Okay, the government is not printing. They are printing more money, but not for us. And so you got to realize. So all you want to do, and again, just by being here and understanding that, all you want to be is in the top half. And some of those measures, the top 75%. You just don't want to be with blinders on, not changing what you're doing. And that's things like you can't identify in your EMR a smoker and don't say somewhere that you sent them for a program, addressed the issue, made another appointment, did something. You can't have their BMI be 32 and not somewhere say that you addressed it. Okay, and they pay you an extra $25 just for clicking the button to say you gave them a brochure about it. And when they want to come back and talk to you about it, it's another extra $25. There are groups that understand this that are making almost twice as much money as they made 5 years ago because they pick every little dollar out. So patient medical home for women. Again, ACOG was not one of those groups. They went and they urged Congress to get us on board. We want to be part of it. And so we're starting demonstration projects in 5 areas across the country, and we're doing one of them. It's too early to say, are all of our practices going to do it? Are some of our practices going to do it? It looks like we're going to have some of our practices that are going to focus on this, because I don't need to have a nurse talk about nutrition or smoking cessation in every one of them. I have 60 offices, 153 OB-GYNs and 60 offices that work for me. I don't need to have one in every office. I can just have 5 offices that have this available and even go ahead and refer them to the office, but at least start it. And we're going to see how much it is. The financial rewards, again, are uncertain for now. And again, we need to understand all this a little better before it evolves, but it's evolving now. So here are the things we have a patient-centered medical home will have to do. They have anemia. They have 2 family relatives that have breast cancer, especially one under the age of 50. You do the contraception, you do the chlamydia infection, stuff like that. But for contraception, here's an example of what we're doing. We did a pilot in one of our offices, and we said, we're really going to push LARC, get the doctors really comfortable, get lots of patient information. We're going to push LARC. We pushed LARC in that office, and we dropped the pregnancy rate by 40%, because everybody says 49% of pregnancies are unplanned. So we dropped it. It was so, and our organization's so big, the president in the hospital came by and said, fire those 3 people in office. I said, why? He says, their numbers gone down 40%. I said, no, it's a project we're doing. He says, what are you doing? He says that their numbers went down 40%. The NICU admissions went down. We're wondering why the NICU admissions went down. I said, yeah, but it's a project. I'm working with Dr. So-and-so because we already talked to Horizon Blue Cross Blue Shield. And we said, we can reduce NICU admissions, which is the main cost, which are $120 million for Blue Cross Blue Shield for our institution. We can reduce them by 10%. I know we can reduce them by 20%, but we're promising them 10%. We want to share on those savings. We're having those negotiations. He said, we'll have the negotiations, but don't do it until after you get it in writing. And it's not gone anywhere because the guy that was negotiating with Blue Cross Blue Shield was then hired by Blue Cross Blue Shield, and I'm starting from scratch again. But anyway, his example, so we went ahead, and one of the bonuses was you get $5,000 if 25% of your patients are using LARC. We're going to have X amount of savings. If you can spend the time to talk to instead of just handing a package of sample pills out and tell her to come back, and call if she wants some more, and then find that 6 months later she took them inconsistently and got pregnant and didn't want to get pregnant. And then she didn't make her first appointment because she was hoping that she'd miscarry. She didn't miscarry. Now she got late prenatal care. She couldn't get her nuchal translucency, and now she's got a big problem with her baby. We could have avoided all that. And we looked at those numbers, and the savings is immense. But if you reduce your pregnancies, you're going to reduce your business too. So we'll send, if the doctors use that, we give them extra money to do that. Now we plan, if you're not spending as much time with pregnancy care, you're going to see other patients that hopefully will bring you more money. And everyone's doing much better. Everybody's doing very well. But these are the things you have to have. Domestic violence, you're going to have to screen for that. You're going to have it in your EMR. You're going to have to address it. So there's a lot of things, but most of these things you do. You're just going to have to document it. If a patient is over 60 and needs osteoporosis screening, your EMR is going to say, our EMR is going to say, patient qualifies for osteoporosis screening, please sign the referral or send to this office. Syphilis testing. These are things you do. So I think that's where you'll be in a couple of years. Right now, don't worry about it, but start preparing your office. I think almost all of you have EMR now. There's a page about smoking for a reason. There's your BMI's developed, because for a reason. So clinically integrated networks. So healthcare networks are forming clinical networks. You don't have to be an employee. You can be an independent practice, but you got to be in a network. The networks have primary care doctors and specialty doctors working together. So when there's a pathway or protocol that needs to be instituted because they developed a contract with the insurance company to do it, like the oncology group, you can do it. If you don't have the docs as part of the system that in writing sign that say they will participate, then you have to train them all about the protocol. They can say, no, I don't feel like doing it, and you don't achieve the savings. We tried that. We'll see it. We'll see it in a second. We tried that before to incentivize the doctors. We'll give you X amount of dollars if you follow these protocols, and they did sometimes, but they didn't do it enough to get the savings to be in the top 50%. So we said, we're just going to have to change the model, and that's getting you into a network, and working with you. Everybody said, oh, the doctor said, isn't that nice? Meridian gave us all EMRs. They didn't give you EMRs because they were nice, cost them $30,000, $40,000 for each doctor. They gave it to you because they want to have access to your data. They want to say, you know what, you promised that you would vaccinate 90% of the people in your office, and you're not because the vaccines are too expensive to have in your office, or you don't have enough space for a refrigerator. Get a refrigerator because you're below standard. So main thing is collective financial investment and reporting systems. It's the EMR's nice, but it's I promise we get done 15 minutes early. Okay, so here's what a typical measure is for Medicare.gov. You can go ahead and an organization could look you up and say, gee, I think we'd like to hire that person, or I think we'd not like to hire that person. It'll tell you about mortality, admission rates, your patient satisfaction, everything's there. We don't use that as much because we have an internal system and called Crimson. And Crimson matches everything you do to the penny. It'll tell us how many specialists you refer to, how much each patient with each code, with each diagnosis, it costs the hospital and you to treat. It then also measures the other things: mortality rate, wound infection rate, bowel and bladder perforation rate. It's a 3-page report. It compares them to everybody in our system, all the docs in our county, all the docs in our state, and all the docs in the country. Because again, New Jersey does a really bad job in a lot of things. I don't really understand. I've only been there for 4 or 5 years now. I don't understand why, but they already know already that even though October hasn't come by, there's no way they can make it up. Every hospital is going to be penalized for some of these measures. ICD-10, I know you got some lectures about it. The only thing about ICD-10 is, again, documentation. You're lucky. We're all lucky. It's very complicated, but it's up to the coders to do this. You just have to give the right information to the coders, and then they can do their job. If it was supposed to be October 1st, if you didn't have it done right, you wouldn't get paid. With the delay, ICD-10 still comes October 1st, but you don't have to be that specific. If you get 3 of the codes right, they shouldn't penalize you. Okay? So and I think the coders can do that. When it gets down to things like laterality, you can't dictate. You can dictate. When it's simpler in your procedures, instead of saying a hysterectomy with unilateral salpingo-oophorectomy, you got to tell them it's right or left. Now they can read through your note, but they're going to skim through your note. They got lots of notes to look through. They'll find it, but make it easier for them. If there's one code, and we'll go through it, that's for if you left something behind. If you left a stent behind, just dictate it in your procedures, because they have to have it. There's a whole code just for if you left something behind. So we'll go through it quickly because this is the fun thing. I don't know if you knew, and I looked through the other lectures slides. I didn't see that. WHO was just developed after World War II, and they decided that to make everything uniform across the world, they would come out with a system of international classification disease, and they didn't know it was ICD-1 at the time. It was ICD-1. Every few years they changed it, and ICD-9 was developed in 1977. It took 6 years or 7 years for the U.S. to adopt it, and so we've had it for over 20 years. And there were 3 volumes, 2 for diagnosis, 1 for inpatient procedures. ICD-10 was developed 20 years ago, and most of the world is on that. In fact, most of the world is going to go to ICD-11 pretty soon, and we're just getting to ICD-10. Everybody's afraid of it because more codes. You don't have to remember one single code. Plus, now there are apps. If you wanted to know the code, you could app it, okay? Because you know what you did. You don't have to. The coders are going to do this. They're not going to trust us anyway. So there's codes. For disease classification, again, there's 2 sets of codes. There's not one ICD-10, there's 2. ICD-10 for disease classification and ICD-10 for procedure classification system. That goes from 4,000 to 87,000 codes. So don't say, oh, this is going to be, you don't have to do anything but dictate your note or write a note that says what you did. Okay? The coding depends on documentation. You're not going to have that many not otherwise specified because they pick on everything. The diagnosis codes. Here's the chapters. Most of us is going to be chapter in genital disease and pregnancy. There's some in infections for me up here. Okay, and you don't have to memorize this, and it's just for us to look at. They're going to base things on trimesters, and it's the trimester that occurred. If something happened in the first trimester, but you didn't treat it till the second trimester, it's first trimester. First trimester is 14 days. Second one's 28 weeks. 14 days to 14 weeks, 28 weeks. So every 14 and until delivery. And the last character, I show you the characters. Let's see what happens here. There you go. Postpartum period is the same like in the past. Delivery to 6 weeks. Peripartum period is defined as the last month of pregnancy to 5 months afterwards. So 6-month window, 1 month before, 6 months after. Structural changes. So basically, you got this is our ACD-9. This will be our 10. Okay. So you'll have, so third stage, different things. So procedure coding. It's only used to code inpatient procedures. Okay, your office is going to continue on the CPT system. You submit a bill. You supply all 7 characters. Now, remember, you should try to get all 7, but if you get 3, they'll accept it. Okay. So first one is the section, then the body part, then the root operation, then the body system, the body part, the approach device, and the qualifier. We'll go through this quickly, and again, just for fun. So the section, the first one is, it'll be a section of obstetrics, okay, or anything else you want to look at. But let's say it's obstetrics. All right. Second, body system. What's your body system? Female reproductive system. Again, pretty simple. Your coders are going to be able to do that. Root operation, and that's the only difference. And the coders, what the training you're going to get from your hospital and from your people is about this. Is about how to dictate or how to write your note. There's not removal. Well, there's removal here. There's not when you say the hysterectomy, you have to take something away. You have to do extraction. You have to transplant. You insert something. You remove. And again, these are for devices only, or mostly for devices. Repairs. So those are the terminology. That's the terminology you have to learn. It's not that hard. The body part is going to be, where the body part was. The approach. Open, percutaneous, via artificial opening, external. I'll give you some examples just to. Then device. It's really important. Again, one of the main two differences you're going to have to talk about: what the device you left in. Did you leave a catheter in? Did you leave a drain in? Did you leave, for cardiology, it's going to be, did you leave a pacemaker behind? But for us, it's mostly drainage devices. And then qualifiers. are not so much to do with us. It's amputations and grafts that use synthetic grafts, and not many qualifiers. So building a code. So it was obstetrics, a pregnancy, delivery. You assisted the passage of a product conception from the genital tract, so you delivered it. The product conception, you took the product conception, the baby and the placenta out. You took them out. No device was left behind, and there's no qualifier. So they'll be able to build your code if you tell them what you did. If you left so main things, you've left the device behind, right side, best side. Medical procedure, anatomic groin, division, perineum, female, external, no device, no qualifier. Okay, I think that's the. I would ask you, what do you think that is? Episiotomy. You divided the perineum. Okay, midline episiotomy. Okay, medical surgery, general anatomic region general, repair, perineal female, external, no device, no qualifier. You've repaired the perineum. Okay, so when you code, so they're going to code when she had a vaginal laceration. You didn't do episiotomy. You have to first say if it was a episiotomy or not. If it wasn't episiotomy, you'll have a code for a perineal repair. Normal deliveries, you can see perineal repair, building a code, medical surgical, female, restriction. We're restricting something on the cervix through a natural opening, no device, no qualifier. You put a cerclage in. Okay, you restricted the cervix with a cerclage. So those are the things that coders looking for to explain what this is. It's almost a story. That's why I think it's fun. We're just kind of taking guesses. So, I told you ahead of time. Laparoscopic tube. Well, what happens? It's not supposed to be up there. Medical surgical, female reproductive system. You occluded something. You occluded fallopian tubes, and both. You could do right, left, or both. You have to define both. And if you was missing a tube already, you can't just say the tube ligation. Your coder's going to go back and say, did you occlude both? And then you say, well, she didn't have both. She only has one, and you say one. You did it endoscopically. You left the device in there. You left the clip. You left the clip in there. Okay, and there's no qualifier. So it's pretty simple, but you'll get the phone calls from the coders because we're not used to doing that specificity. We're going from 4,000 codes for them to 80,000 codes for them. There's a lot more specificity. There'll be questions, but it won't be a problem. So total hysterectomy is not one code, it's several codes because you took out, so you resected and you excised, and so you build in the code for hysterectomy, medical surgical, female reproductive system, you resected the uterus through an open procedure, you didn't leave a device behind qualifier. But that's the hysterectomy because that's the uterus. You take the tubes out? Sure, you took a cervix out too. Medical surgical, reproductive, resection, cervix, open, no device. Okay, that's the cervix part of the hysterectomy. Again, you're used to charging and billing for a hysterectomy. The code's going to let you bill for removal of a cervix, removal of the uterus, and then if you remove the tubes, the same thing. You got, you'll have one for ovaries and one from bio. So you'll have 4 codes for the hysterectomy you did before. Okay. Now, I don't think you're getting any more money for it, but you'll have 4 codes. Endometrial curettage, medical surgical, female reproductive system. You extracted, the tissue. You extracted endometrium through the cervix. No device, no qualifier, and that's it. Endometrial ablation, medical surgical, female reproductive system. You destroyed. Remember, you have to understand how it works. You could extract if you did a bipolar removal or extraction with the device. That's different. So you destroyed the endometrium. You did it through the cervix. You didn't leave a device behind, no qualifier. So that's ICD-10. And again, I wanted to, like I said, give you extra few minutes that Propel gave us. And I'll stay for questions. So know it's happening. 2015 is the big year where 1 or 2% of the incentives the government gave to get you on the EMR and start working on this now go away. You're supposed to be able to know how to do it. Your system's supposed to know how to do it. Luckily, OBGYNs aren't in the main forefront of the losses they're going to get, but they're now monitoring you. If you're part of a system, whether you are employed by them or not, they will have a system in the hospital. They have to have it to report to CMS. They have to have, otherwise they get penalized 1 or 2% for not having a reporting system that they can use. And so they will know this data. So by next year, you'll get a report, and they'll say, you need to improve this, you need to improve that, you need to improve it. You hope that they give you time to improve it. If they're a system that's doing poorly and they don't have time to fix it, they'd rather not have you in the system. You know, they want to grade by the curve. You know, they want to not have you in the system and change their curve, okay? Because it's not, you cost them, in your report it says you cost them an extra $1,000 per patient because of your practices and you didn't get the results you wanted. It's gonna, they don't care about your 1,000, they don't care about your 100,000 if you had 100 patients in the hospital. They care about their 50 million they're going to lose because your score dragged them down below the 50th percentile. And I think it's going to be a very regular curve. A lot of people are going to be in the middle, and a lot of people are going to be on the fence about whether they make it or not. And they lose if they're, you know, if the profit's 2% for a hospital doing pretty well, you know, and they lose two sections of 2% each, they'll lose money that year, and they have to fix it by the next year, otherwise they'll be gone. So any questions?